Okay, everybody, good afternoon. Welcome to this ERKNet ERA EDTA webinar on the genetics of stones. My name is Tom Nijenhuis. I am a nephrologist at the Radboud University Medical Center in Nijmegen, the Netherlands. And I will be your moderator today. And it is my honor to introduce our speaker of the day, which is Shabbir Moochhala. Shabbir trained in Edinburgh and Newcastle upon Tyne. Has a long-standing interest in renal physiology, particularly in renal stone formation. His PhD actually was on pyrophosphate transport in the physiology in the kidney, and he runs the metabolic renal stone clinic at the Royal Free Hospital, which is actually the largest of such services in the UK. He has an interest in rare renal diseases, of course, as we all have. And is part of the National Renal Rare Disease Registry Network, known as RADAR, in the UK, and was recently appointed as the lead for the newly created NHS Rare Disease Clinical Network for Hyperoxaluria. And in addition, he was part of the committee that wrote the NICE guidelines for renal stones in 2019, and is a principal investigator for a number of interventional trials. So I think he is the right person to tell us more on this timely topic of genetics of stones. Shabbir, the floor is yours.
Thank you very much, Tom, and thanks very much to the ERKNet group for kindly inviting me. So I'm going to start, first of all, by just giving my disclosures. So the main disclosure I want to make is that I'm not actually a geneticist, so I don't really have any formal training in this, and I also know very little about pediatrics, but I'm hoping that I'll be able to show you that even though I'm not a geneticist, that doesn't really matter when it comes to talking about the genetics of stones, and it might even be an advantage. So before we start, I'm just going to, because I can't see you all, I'm going to ask who's in the group today. So this is just gives us a bit of practice with the voting. So if you just, let's go to the polling question first of all and just work out who we are all today.
So we are waiting now for most of you to vote. Once you've done so, we will see the results. Okay, so Shabbir, here are the results of your first poll. Most of us, about 77%, are nephrologists. 15% are nephrologists in training. 5% are scientists. 2% are geneticists, so that might be positive. 2% are urologists.
Excellent. Thank you very much. That's great. That's kind of what I expected, but it's just nice to know. So welcome everybody. A brief outline of the talk today, just a little bit about the background to kidney stones and where we are now, about family history, and we talk about family history a lot, but how useful is that in real life? How to recognize monogenic stone diseases. I'm going to try and keep that bit quite clinical, so hopefully there'll be a few tips in there, and then just some conclusions at the end. We'll start off with the epidemiology aspects. As you know, this is a growing problem. It's getting worse. This is data from England over about a 15-year period, and it shows that there's about a 70% increase over a 15-year period of kidney stones. And this means not just admissions, but also procedures, which is quite a big problem. One of the reasons why I really like working on this area, I'm also a general nephrologist, as of course I'm sure most of you are. One of the reasons is that it disproportionately affects people of working age, as you can see in the second figure over there. So it's quite useful to be able to give people some sort of preventative strategy or even a diagnosis. And it's also really important from a public health viewpoint as well, because you can see the red lines here show that the number of procedures that urologists perform for kidney stones has increased tremendously. They're all really expensive, and if we can do anything to try to reduce this burden, it's not only good for the patients, but it's also good for the healthcare system. And it also keeps people away from the urologists. When I think about stones or the genetics of stones, I don't just stop there. I don't think about the genetics just by itself. I also think about these other areas. It's really important to understand that at the moment, we've got a lot of information about risk factors, and actually a lot of those risk factors are very easy to understand from the patient's point of view. So actually for them, that it really speaks their language when you talk to them about some of those risk factors. When I talk about stones or think about stones, I also think about bones, and it's really important to ensure that we're treating and preventing bone disease as often as we can. And then there's also cardiovascular risk, which was quite a big story when it came out around 10 years ago in terms of the association of cardiovascular disease with stones, but there's never really been any further mechanism type research that really shows us what the link could be. And so all of these things are of relevance. So let's now move to specifically look at the genetics. So family history, of course, we know is a risk factor. If you have that in your patient, then that is in itself a risk factor for recurrent kidney stones. And certainly it's known that around 30 to 50% of stone formers have got a positive family history of stones if you ask them. And that's important because if you have that sort of history, you've got a 2.5% increased chance of having a first stone in somebody who's got a positive family history of stones compared to someone who doesn't. That's quite a big increase. And similarly, this is a study that was shown using the Swedish population, and there's a clear difference between patients who do have a family history of stones in terms of their rate of stone production compared to those who don't. So genetics are important. We don't necessarily know how, but it's not the full story. This is a study about twins that was done some time ago, and it showed that these are the concordance rates that are shown over here. And in summary, it's really showing that only about half of this heritability, if half of the risk is heritable, and so the other half is environmental. But when we think about environmental, it's not just what we think about in terms of obesity, diet, and all of the other things that we know about very well. We also have to think about the internal environment. And that would be, for example, in this case, someone who's had gastric bypass surgery. That's a change to the internal environment, which might make them more prone to have, for example, hyperoxaluria. So both of those things are important. And as I said, some risk factors are modifiable, and it's important to understand that, you know, quite a lot of the risk is modifiable because quite a lot of it is not genetic. This is a study by my friend and colleague Manuel Ferraro, who looked at about 200,000 participants across 3 different studies, and 50% of the risk was found to be due to modifiable risk factors. So they're big numbers, but really no big surprise. And the risks are really all the standard ones that we can see over here. All these things, so low fluid intake and calcium, needing to have a decent calcium intake, and the fruit and vegetable story. These things are not a surprise. It might even be a bit boring for us in the clinic. But really, at the moment, if you want the most effective way to prevent stones in the population, then this is what you need to talk to your patients about. This is as good as the science gets. Let's go back to the genetics now. So let's try and work out, well, which genes are responsible for stones? One of the ways to look at this is by taking a group of stone formers and non-stone formers and doing genome-wide association studies. And this has been done a few times. Here's an example from a recent paper of some of the candidate genes that come out of that. What is this telling us? I think that instead of really being a collection of rare diseases, which is what maybe one original hypothesis was, stone disease in general isn't like that at all. And these are candidate genes. They're linked to traits They're not causes in themselves. It's important to understand that these are not causes in themselves. That's really about as far as we've got with this, because there's so many different possible candidates, and of course they don't link up. Most of them don't link up with the lists of monogenic diseases that we have already. So we start off with a GWAS by determining the phenotype of interest. So we could then say, right, well, why don't we just narrow that down? Because we know that stone disease is extremely heterogeneous. Why don't we narrow it down to just look at certain groups? But even that isn't always that easy. So for example, this is a patient from my clinic, 62-year-old lady, screen positive for cystinuria. Sounds easy, but bilateral nephrocalcinosis and hypercalciuric, well, the diagnosis there turned out to be something completely different. And another one over here who's got ammonium urate stones, very unusual stone type, but also uric acid stones mixed with calcium oxalate. And this patient turned out to have distal RTA. So it's not always easy to actually group your patients and try to work out even what the phenotype is. Let's go into more detail now on the monogenic causes of stone disease. So there's a number of studies that show that when you look at them in total, there's about somewhere, it says 15 to 34% of all stone formers having a monogenic cause, which is obviously very exciting. But when you look at these studies, they've all been done using specialist medical stone clinics. In the same way that, that I run a specialist medical stone clinic, I can tell you that the rate at the Royal Free is 13% in terms of stone formers having a monogenic cause. Which is great from the point of view of running the stone clinic, and of course a lot of them turn out to be cystinuria or something like that. But in real life, that's not how it is. It's actually really only about 2% of stone formers that turn out across all comers that turn out to have a monogenic cause. And again, some of the typical genes that are involved are listed on the right-hand side, but there's plenty of lists available in the literature for that. And it's worth also pointing out that even in pediatric series, only about 17 to 20% of stone formers actually turn out to be monogenic. And one of the reasons might be that we're missing out, missing patients. There's a lot of autosomal recessive disease around, but whatever it is, there's clearly a lot of non-monogenic disorders, and that's what we need to try to understand in more detail. So we need some clues, we need some clinical hints that will help us in the clinic to try to identify these people. And again, when we look at lists, there's plenty of lists available in the literature. Here's an example. I always try to have a quick mental picture of what we need to look at. So here's how I normally just try and break it down so that you've got you can apply this to almost every stone patient you see. Are they young? Do they have a family history? Do they have very frequent stones? Is there something there that looks like it could be a tubulopathy? And is there an unusual stone type? I think those four would cover most of the potential clues for monogenic stone disorders. And just to sort of elucidate on that, for tubulopathies, these are some of the clues that you might want to use. That you can get most of these with just basic or stage 1 testing without having to do anything too fancy. And it would give you a rough idea as to whether that's something that you're looking at. This is also important because there are various guidelines available, probably more towards the urologist, directed to the urologist rather than to us as nephrologists, but we need to be aware of them. And the one thing that's changing now is that there's an increased focus on this sort of basic stone screening. So, for example, in the UK, NICE have recommended that all patients have a serum calcium measured. That's all stone patients. That is a lot of stone patients. So we're going to be getting loads of calcium results, which may or may not mean anything, but we should really be, rather than saying, well, that's not an unnecessary or a bad way to investigate these patients, we could then use that and say, well, look, it's a lead in to trying to understand who might have these sorts of conditions. And when we do that, we try to replace what you see on the left-hand side, which is the classical picture of the stone type distribution that we see amongst all stone formers. We try to replace that now by putting the genes in that are going to be or potentially of relevance to each of these categories. And classifying by stone type is, I think, quite a good and robust way of doing it. Just bear in mind, though, that when you're looking at this, even though there's loads of genes, for example, for calcium oxalate stone formation, the proportion of patients who actually have one of these disorders is extremely small, even out of this big blue area. Whereas the patients in the rarer stone types, so for example, this red area here, who've got one of the cystinuria gene deficiencies or abnormalities that give rise to cystinuria, that's going to be a much higher proportion of that red section. So it's really important that we use that as a clue and just say, look, if we've got an unusual stone type, then that straight away makes looking for an underlying cause that much more important. And then, of course, there's two main ways of screening these patients, and you can see the difference here. There's clearly a good argument for doing genetic screening in selected patients. That's obvious. Doing it across slightly less well-selected patients, that has not been shown or proven. And it's going to be, although the cost of this thing is rapidly dropping, what's going to happen is the noise is going to start to increase. And there's other points that just need to be made regarding the metabolic screening, which of course, as we know, is nowhere near precise. It's plagued with all sorts of collection problems and all the things that we know about. Patients don't particularly enjoy filling up these 5-litre bottles. But the chance of once you've made your, if you think you're going to make a genetic diagnosis, then clearly you're going to go to a genetic screen. But even in the 15% who do not, sorry, 15% of patients have monogenic disorders, even the rest of those patients, the 85% who don't have monogenic disorders, you can still treat risk factors. And again, it sounds boring, but actually it's really important, because the two main risk factors that will yield the best possible results in terms of numbers of patients being helped in terms of stone reduction are urine volume and urine calcium, both easy to obtain on a very cheap metabolic screen. You don't even have to do all the rest of them. So just by doing those two things, you might actually be able to treat or reduce risk in patients without having a diagnosis. Not scientific, but very practical. And that does have some merit, because as we saw earlier from the earlier slides, up to 50% of the overall risk might be treatable simply just by doing this. And because that's the bit that we can alter. It's the non-genetic bit that we can alter. So now some caveats. Some stone diseases, they don't actually present with stones at all. That just makes it even more difficult. So here's an example. One patient who came to my clinic, we had a patient with CKD gradually getting worse and nothing else really. Renal biopsy gave the diagnosis here. You can see the classic brown stones of 2,8-dihydroxyadenine. This patient had APRT deficiency, confirmed, easy diagnosis once you've actually thought of it to make, easy to treat. Sure enough, this patient has been prevented from ending up at end stage as a result. I saw this patient last month. So it's important to remember that certain genetic stone diseases don't even necessarily give stones. And another example of that would be nephrocalcinosis. There's plenty of patients who have nephrocalcinosis that but it's important to realize that those patients, it's the medullary nephrocalcinosis is really what you're looking at. If it's cortical, it's quite often due to acute kidney injury. Let's look at another patient now. This is someone who is 39 years old, had a nephrectomy for stones, comes in with acute kidney injury, and the remaining kidney is now full of stones. So this obviously rings a few alarm bells. Calcium oxalate stones. Chronic loose stool was noted on the history. In fact, this patient had had some gastro investigations that did not yield anything a couple of years ago. And in the follow-up clinic, the creatinine is now 115. And when they did a 24-hour urine collection, they found that the patient had hyperoxaluria. I'm going to ask you now to vote on what you think the diagnosis is, bearing in mind that story.
So the likely diagnosis is either primary hyperoxaluria, secondary hyperoxaluria, ethynyl glycol poisoning, or primary hyperparathyroidism. So please put in your votes for the poll. We are eagerly awaiting the results. And here they come. Actually, nobody thinks that it's hyperparathyroidism. 1% of the people think that it might still be ethylene glycol poisoning. And then we have most of the people thinking it's secondary hyperoxaluria, but also a rather large part of the people, 35%, thinking it's primary hyperoxaluria.
Great, thank you, Tom. So that's kind of what I expected, actually. Thank you very much for taking part in that. So yes, I think the differential would be between primary and secondary, but this sort of case just shows how difficult it is in real life to be able to distinguish just once you get to clinical grounds. Now, obviously, at this point, we would want to genotype the patients and just make sure that it is not primary hyperoxaluria, but it's not always an easy diagnosis to make. And you can quite often get secondary hyperoxaluria where the patient's been assessed by a gastroenterologist and yet nothing has been found that, that shows an underlying cause. That does happen from time to time. So sometimes it's not always easy. I'm going to show you some of a few more of these cases, but the thing to remember is not so much all the clinical details of each individual condition. It's this red box at the top, because this tells you the important bits. It tells you where the defect is. It tells you what kind of inheritance it is, but also really importantly, it tells you whether or not, if this patient ends up having end-stage kidney disease, whether we need to be ultra careful before we recommend a renal transplant. And of course, in this case, it's really important because primary hyperoxaluria is a liver disease, not a kidney disease. And therefore, it's really important to appreciate that and to make sure we've made these diagnoses in patients. And sometimes, especially when they present in adulthood, patients do not have that much in the way of stone disorder sometimes. It's often the case. There's a lot of work going on in the world of primary hyperoxaluria at the moment. This is just an example of shows the biochemical pathways. Because it's so complicated, in a way it's good because it gives you multiple opportunities for drug targeting at some of these enzymes and end products. So that's a whole separate story, but it's just to let you know that once we know the mechanisms, it becomes that much easier to try to design drugs. Here's another one. This is cystinuria, of course, very well known, and of course the commonest inherited stone-forming tubular disease. And unlike some of the other genetic diseases, I keep saying how important it is to make these diagnoses. Well, you could argue in the case of cystinuria, we don't actually need the genetics at all, because once we've made the diagnosis, we use the genetics neither to guide the diagnosis nor the treatment. We make both of those things are done in non-genetic ways, and yet this is an absolute classic stone-forming genetic disease. So some top tips about diagnosis of cystinuria, bearing in mind I said that we don't normally work this out on a genetic screen. Sometimes the urologist will tell you that they have this funny smell when they laser vaporize the stone, but of course there's plenty of other classic ways in which this is diagnosed. But whenever we make a diagnosis, a genetic diagnosis or any other kind of underlying cause diagnosis, we just have to think whether it makes clinical sense. So if you look at this example, this is somebody who's only 34 years old, made calcium oxalate stones and needed some treatment for it, had a family history, but screened positive on a cystine screen. So this patient was originally labeled as having cystinuria, but clearly this cannot be cystinuria, even though when this patient was genotyped, they had an abnormality in SLC7A9. They had a mutation there, which is a known mutation. So the question really is what is this? You know, this is not cystinuria. You can't possibly say that this patient has cystinuria, but equally they do have an abnormality of the cystine of the dibasic amino acid transporting genes. We'll move on to the next case. So this is, again, trying to illustrate a few points here in terms of the diagnosis of renal genetic stone disease. This is somebody who is 52 years old and has stones, which have been going on for a long time, and has worsening CKD stage 4, and it's progressive. So this is not just the acute kidney injury you'll get during a stone episode. This is an ongoing progressive CKD. And this patient had a family history of stones and renal transplant. Specifically, that person in the family was his uncle. See if you can work out, this is the next poll question, which of these tests would be the most helpful diagnostically given this information. This is a bit of fun, it's quite a hard one, but see if you can work out what I'm getting at here. You need to have an idea what the diagnosis might be. Shall we vote on that one, please?
Okay, everybody, let's try to vote what we think would be the best or at least the most helpful diagnostic test in this case. We are at almost 60% voted, so we will wait. It's clearly a more difficult question because it takes everybody a little bit more time to vote. Okay, we close the polls, and indeed the results are divergent. So Shabbir, for you, because you cannot see the poll results, the top result is the infrared stone type analysis with 29%. Then a good runner-up is the cystinuria gene exon sequencing, actually equal to the 24-hour urine oxalate excretion. And then the renal biopsy and the urinary retinol binding protein excretion are at about 13 to 15%.
Thank you very much, Tom. That's great. And thanks everyone for playing along with this. This is a hard question, but the thing I was trying to get across was that this is an unusual condition. This is called dent disease. Like cystinuria, it is a proximal tubulopathy, but the mechanism is completely different. It does cause, because it's a proximal tubulopathy, it gives rise to this low molecular weight proteinuria. So actually the answer was the low molecular weight protein excretion, so it was C. But don't worry about that. The main point is just to show how difficult it is sometimes to diagnose these conditions. Even when you think there's clearly something going on, it's not always easy to work out. But this is one of the things that is easy to work out in clinic. When you're testing the urine and you're sending it off for a protein to creatinine ratio, it's easy enough to send it for a retinol binding protein in centers that are able to do that test. Just done on a spot urine, really good way to exclude a proximal tubulopathy if you suspect that one might be going on. And these are some of the clinical features that you would expect in that situation. So again, this is another transporter defect, a bit like cystinuria. So you can see that there's a bit of a comparison over here between the two conditions. We'll move now just to another case, but there's no voting on this one. I just wanted to point out a few things about this. This is a young person who comes in who's got medullary nephrocalcinosis and stones from a very early age. So clearly there's something going on here. Plenty of procedures in the past, calcium oxalate stones and hyperoxaluria. So if you were to just stop there, you'd think, right, well, this looks like a typical case of primary hyperoxaluria, and that would be entirely reasonable. There's a family history of stones. When you look at this, high vitamin D, low PTH and hypercalciuria, again, that's a classical phenotype of the vitamin D receptor gene, the vitamin D 24 hydroxylase gene abnormality, CYP24A1. So when you see that combination, you might think that there's a problem with vitamin D metabolism. That's what could be causing it. But when you take the history, it turns out this patient spent a year traveling around very hot, sunny countries, and these measurements were taken just after that patient had returned. It's only when you do the acidification test that, even though the urine citrate was normal, some other features were present, which gave this diagnosis of distal renal tubular acidosis, and the patient was treated and improved after that. So it's just important to realize that a lot of these patients present in all sorts of rather atypical ways, and one rare condition can look very similar to another rare condition. So you've got to make sure that when you assess these patients that you're looking at the whole clinical story and seeing and just checking that it actually makes clinical sense. And again, DRTA, another transporter defect here, with varying types of inheritance depending on where there's more than one transporter involved. It can give rise to more than one problem. Important also to diagnose these conditions, not just for the patients or their families, but also from a research point of view. Registries are available throughout Europe, and so this is available via the European Rare Kidney Disease Registry, but also each country has its own mechanism for registering patients with rare diseases. In the UK, you can see that the highlighted conditions are stone conditions amongst plenty of other conditions, but surprisingly high proportion of stone forming conditions among the general rare diseases that are there on the UK radar registry. And it's really important as well, just from the point of view of making sure that all nephrologists understand that this is actually a really important area. And I know that, even among my colleagues, renal vasculitis and renal transplantation, these are the two areas that are most popular for registrars and trainees to go into and do research in these areas. But actually, stone disease, and in particular rare stone disease, they're actually, I would say, in some ways more common. Well, stone disease certainly is, and it's really important to have more people interested in this area. And the diagnosis is difficult for the reasons that we've said, that we don't always, there's overlap sometimes clinically, we don't always have a definite answer, we don't always have a family history, we sometimes don't even have stones. So it does make it more difficult, but therefore more interesting. So conclusions then, I will try and keep it practical, but I hope you've seen that you don't really need to know that much about genetics to be able to diagnose genetic stone forming conditions. You do, on the other hand, need to be a clinician who can look at these patients and with interest and try to decide on what clinical grounds which stone forming patients you are going to investigate. You cannot investigate or treat them all. That's not your job. The urologists are already doing that. We've got to decide who we're actually going to look at. But I would say that at present, the pathophysiology is the thing that is most important. It directs what you do with genetic tests. That may change in the future. In fact, it probably will change in the future as the genetic testing gets a little bit more sophisticated and cheaper. But in the meantime, we mustn't forget that some of those monogenic stone disorders that I provided some examples about, they really must be identified, and that's to avoid recurrence in renal transplant. And you often see this, it happens a lot, it gets reported from time to time in every centre. There's always some problem that can arise sometimes. It's not easy, it's really difficult, but you've got to try to remember the clues, and sometimes that can be a help. And remember, whenever you talk about stones and we get very excited about the genetics, don't also forget that this is essentially a form of lifestyle disease. It's associated with obesity and cardiovascular disease, and that's going to be some of the genetics of those conditions, I think, may also be associated with some of the polygenic aspects of stone disease inheritance. And that's the end of the talk. Thank you very much for listening.
Okay, Shabbir, thank you very much for this presentation. I think it is very enlightening, and it also shows us that we have to look at the patient as a whole, I think, right? and don't just do a general checkup and a general stepwise approach. While that is, of course, easier, probably, right? I'm looking whether we already have some. We already have some questions, but maybe I can start off with the first question that is actually in line of what I just said. If I talk to geneticists nowadays, they always ask me, well, is this a topic where maybe a first genetic screen could be a good way to guide, let's say, the clinical thinking about patients. So if these genetic tests would reduce in cost to, let's say, 50 euros, 50 pounds, would it then be a good idea to give all these patients a genetic screen before we actually take a good look at the patient?
That's yes. I think it looks like it's starting to head that way, doesn't it? I think without understand, it depends really what the aim is. If we're trying to do this as a research project, then I would encourage that. I think that would be that's a really good way to try to understand more about what genetic screening means. But if we're doing it as a diagnostic test, then I think it's much more difficult to justify, because you're then into the realms of finding variants that mean nothing really for the patient. And a good example would be, for example, finding an abnormality in one of the cystinuria genes. It may mean something, it might be a risk factor, but it's not a diagnosis, and you can end up then spending many hours in the clinic trying to explain why the patient doesn't have what the genetics said they had.
Mm-hmm. Yeah, because nowadays we can do all these old genome or at least some exome sequencing with panels, but the question then is, like you show in one of these patients, when you see a variant, does that actually mean that is, let's say, the cause of their disease, right?
Exactly, exactly.
And maybe also before we as nephrologists actually start thinking about these patients, what should we actually tell the urologist about sending these patients to our clinics? So should they send all patients or should they do a type of screen before they actually ask us to think about the patient?
That's a really good question, and of course the answer depends very much on where you are, where you work, and what your setup is. I think for that reason it's good to probably just have a chat over a coffee with your friendly urologist to try and work out what works from their point of view. The last thing we want to do is flood our clinics with patients who, in whom we're not going to be able to make a diagnosis. That's not the aim. We certainly don't want to do that. I think you saw from the studies that that you can get, when you have an enriched population, you can really do some good. You can really get some good information, and so that's why I would advocate a sort of decision-making process along the lines of deciding who might be potentially going to have a monogenic disorder. It's a very loose way of thinking, but at least it gives a framework to try to prioritize. And then if you can only see 5 patients a year, at least you know which 5 you're going to see. And if you can see 500 a year, then you can broaden out the criteria. That's the way we're trying to do it. So in my center, we're doing that. We started doing that a few years ago. It's worked quite successfully. That's how we managed to get our diagnosis rate up to about 13%. We're now expanding that, so we're trying to make electronic criteria so that it helps the urologists find some of these patients as well, which they are now mandated to do, but it avoids trying to flood our clinic. So I think a bit of balance somewhere in between is what's needed.
Mm-hmm. And maybe a very practical question from my side, and then I will see whether there are any new questions in our Q&A. Let's say in my experience, some of these patients might be very interesting what the reason for their stones is, but sometimes are not that interested in medical therapy. And they actually tell me, yeah, well, let's say if I have a stone once in every 5 years and you can reduce that to once in every 3 to 4 years, then, well, if it's a person that has already reached a certain age, then they will say, well, if I calculate that, then you can, let's say, prevent 2 or 3 stone episodes. I don't know whether that is enough for me to adhere to all the medical treatment, dietary advice, etc. If you stand that against doing genetic screens and trying to find, how do you think that the balance lies there?
Yeah, so I think some of this is about patient education, but so far I found that the patients who do engage and will actually do the tests, once they've got to a stage where they're actually doing the investigations, they're really keen to hear the answers, and especially if they are in the group of patients who are sort of young or middle-aged, because they've got a lot to lose in terms of other aspects of their life as well, in terms of work, time off school, time off employment. All of these things make them pretty keen to actually try to do whatever can be done. It's quite a good screening test, because if you try to do the investigations and they don't turn up for it, you've got your answer. They're probably going to be the same people who probably won't adhere to any kind of recommendations or treatment. So you can probably just try your best to give them the general advice and wish them all the best. It's difficult to force people, as you said, to come for treatment, and especially if they're not going to adhere to it.
Okay, so one of the questions here is, and I think the question is it are you practically able to realize the analytics of the stone? If I understand the question correctly.
So I'm assuming that you're talking about stone analysis.
Yeah.
So yes, that's usually the best place to start, because it's, again, one of the 4 criteria that I suggested in terms of looking at or trying to decide whether it's a potentially good patient to screen. It's now done usually by infrared spectroscopy, which is the best way to do it, non-invasive and quite standardized. So most centers can do that, and of course, if they can't, then theoretically you could just pop the stone in an envelope and send it to a center that does do it, because that's not going to be a difficult thing to do. So that would be, I think, the best way to try to subcategorize these patients, because straight away you're going to pick up the rare stone disorders instantly just by doing that test.
Yeah, surely. And the other question that I have here is, what about good hydration? And then the specific question is, what quantity is good and which juice? I guess the question is, should you advise water or should you advise something else?
So there's a lot of interest, and also I would say interests in this from companies and other people who saying that my juice or my drink is the best. In reality, the evidence all shows that it doesn't matter as long as any sort of hydration is there. But it's also important that patients realize that just being dehydrated on its own is not a cause of stones. Lots of people get dehydrated, they don't all get stone disease. So it's a preventative, but it's not an explanation for why people get stones in the first place. So we are still even in those patients, we're looking for an underlying cause, but clearly a secondary prevention, obviously adequate hydration, and it's not even about the total amount, it's about being hydrated throughout the day and especially overnight. And we always find that out of all the patients, our cystinuria patients are the best at this. They're so keen to avoid a stone, and I think some of their patient groups and their social media connections are so good that they are very, very clued up about this and know all the tricks to try to hydrate throughout the day without overdoing it. So they're probably people that we could learn from.
Okay, thank you very much. I'm looking at the Q&A, but I guess we don't have any new questions anymore. So at this time point, I would like to thank you again for this enlightening presentation. And of course, I would like to thank everybody who attended this webinar. And I would like to send you off, but not before telling you that our next webinar will be on Tuesday, the 13th of April. That this will be a webinar on IgA nephropathy and Henoch-Schönlein nephritis. Thank you all and have a good night.
Thank you.